Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Randomized Multicenter Placebo-Controlled Trial of Omega-3 Fatty Acids for the Control of Aromatase Inhibitor-Induced Musculoskeletal Pain, S0927, by Don L. Hirschman et al. My name is Charles Loprinzi. I am a medical oncologist at the Mayo Clinic in Rochester, Minnesota, and the Regis Professor of Breast Cancer Research. My clinical practice primarily involves patients with breast cancer. My primary research interest is related to the prevention and/or treatment of symptoms related to cancer and/or cancer therapy. Let me start off with a quick review of what was reported by Dawn Hirschman and her colleagues. They conducted a randomized, placebo-controlled, double-blinded clinical trial in patients with aromatase inhibitor-associated arthralgias who had pain stiffness scores of greater than 5 out of 10 and who wished to take something to hopefully relieve this pain and stiffness. 262 patients were randomized to receive an omega-3 fatty acid preparation versus an identical appearing placebo preparation. Pain was reduced in both study groups, 6, 12, and 24 weeks following study initiation. At 12 weeks, a 30 to 35% pain reduction was reported. This was quite similar in each study arm, with no suggestion of differences between them. Triglyceride levels did decrease substantially in the omega-3 fatty acid group, but not in the placebo group, consistent with patients actually taking the study substances. The authors rightly concluded that the omega-3 fatty acids were not helpful in this situation. Let me now provide a few comments regarding the manuscript. First, this was an excellent group of investigators who conducted this trial in a well-delineated manner. Their manuscript reads well. The relatively large placebo effect was not particularly surprising. A 40% reduction was seen in a placebo group at 1 and 3 months following study initiation in a previously randomized placebo-controlled trial of a testosterone preparation presented as an abstract at the 2009 San Antonio Breast Cancer Symposium. Of note, this reduction in pain might not all be a classic placebo effect, as it might well be the natural history of aromatase inhibitor-associated arthralgias over a 3 to 6 month period of time. I will now move away from specific commentary on this manuscript to discuss clinical and research aspects regarding aromatase inhibitor arthralgias. It is noteworthy that this problem was not well recognized when aromatase inhibitors were first approved in 1996. There was no notation of arthralgias or myalgias being a side effect in a JCO paper in 2000 by Bonneterre et al., which studied 686 postmenopausal women randomized to receive tamoxifen or anastrozole for first-line metastatic breast cancer treatment. The closest proximity was pain in general, noted to be 8% versus 7.6% in the two study arms. Bone pain was noted to be 6.3% versus 6.1% in the two study arms. The first real association of aromatase inhibitors and arthralgias that I can find was raised in a letter to the editor in JCO in 2001 by Donnellan et al., 5 years after anastrozole was FDA approved. Donnellan et al. Wrote their letter in response to the claim that aromatase inhibitors, compared to tamoxifen, had significantly superior toxicity profiles. This claim came from a systemic review of aromatase inhibitors for the treatment and prevention of breast cancer by Paul Koss and Catherine Strasser. Donnellan et al. Noted that they had seen several patients who had arthralgias, which developed after starting an aromatase inhibitor. A recent prospective series by Crew et al. Suggested that aromatase inhibitor arthralgias were seen in approximately 50% of patients and that they were severe in about 15% of patients. However, since this trial did not have a placebo arm, it could not estimate the nocebo effect, that being the toxicities that are ascribed to an agent that are not really caused by an agent. Thus, the true incidence is likely to be a bit less than 50%. Morales reported in 2008 in the JCO that there was MRI evidence of synovitis and intra-articular fluid in patients who received aromatase inhibitors, not seen in patients who had received tamoxifen. The most likely cause of aromatase inhibitor arthralgias is due to estrogen depletion. Estrogen receptors are present on cartilage, and there is evidence in women that arthralgias increase with estrogen depletion and decrease with estrogen replacement. In concert with this, a 1925 JAMA publication written by Cecil and Archer described an arthritis of the menopause. Currently, the recommended treatment for patients with aromatase inhibitor arthralgias that are not managed by over-the-counter analgesics is to stop the aromatase inhibitor for about 1 month. Symptoms usually improve during this time. It is then common to challenge with an alternative aromatase inhibitor. Some patients again develop marked symptoms after this, while other patients are able to tolerate the alternative aromatase inhibitor. A second option is to switch to tamoxifen. Another alternative is to consider stopping the anti-estrogen treatment if the prognosis is favorable enough from a breast cancer standpoint. Let me finish by noting research efforts in this realm. In terms of trying to find treatments that work, there are multi-institutional randomized trials ongoing looking at acupuncture after a pilot JCO-published single-institution placebo-controlled trial suggested that acupuncture was beneficial, looking at testosterone, and looking at duloxetine. Additionally, there are suggestions regarding the utility of high doses of vitamin D, but these have not yet been established. Another cooperative group research effort is ongoing to try to determine which genetic variants put patients at higher risk of developing aromatase inhibitor arthralgias. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.